Hi guys, this is Dr. Sonali here, welcoming you to the Neonatal Hub. Today, we'll be discussing a very important concept in neonatology, the concept of golden hour. Now, most of you must have heard this terminology in regards to trauma management. Here, in this session, we have discussed the common features and the differences between the two golden hours, that is the one of trauma and one in neonatology. And we'll be discussing what has to be done in the golden hour of neonatology further. So let's proceed. Now, the first hour of life for a premature infant, as we know, it represents a time period during which the infant faces the challenges that carry risks of short and long term injury, along with that, lifelong developmental delay, even death. Now, the decisions which are taken by a clinician during this time is based on multiple systems that require attention, knowing that the care in these first few minutes can translate into lifelong medical problems. In this way, the first hour of neonatal life parallels to the concept upon which is based the golden hour of trauma. Now, what is the golden hour of trauma? Now, in trauma, this is the concept based on time in which it is important to get the patient to a facility where definitive care can be provided within 60 minutes. That is within the first hour. Stabilization of the patient is very important here. That is establishing airway, breathing, circulation till the patient is brought to the definitive center, and then definitive care can be taken. However, in neonatology, the golden hour is the first hour of the neonatal life. It generally begins at birth but can well extend beyond the first 60 minutes of life. This is the phase that includes the initial stabilization, that is maintaining the temperature, airways, breathing and circulation. As we can see, the main point which is different is temperature, because as we know, a newborn requires temperature management along with the ABC, that is, it requires TABC. So, what is done in this hour? Firstly, prompt stabilization of the airway as well as the cardiopulmonary support to establish and maintain vital signs. And as we have already discussed, temperature management in a newborn is very essential for the stabilization. Secondly, it is important to pay attention to the multiple aspects of the patient condition. That is, in this hour, the vital signs, the saturation, and the response to resuscitation is very well assessed. And depending on that, the next steps are taken. Thirdly, there has to be a proper attention to the injury prevention and progression as well. That is, as we know, in a neonate, alveolar recruitment is very important, which may require a PWP. That is, a positive end expiratory pressure may be required, which can be provided by IPPV, that is through AMBU bag and mask, or it can be provided better with a TPC resuscitator, versus spine stabilization, which is very important in a case of trauma, so that further injury to the spine is prevented. And the second example being, we have to prevent the O2 toxicity, which can occur during our management steps in a newborn, versus shock management, that is prevention of shock in case of a trauma victim. Nextly, rapid initiation of vascular access is needed in this hour, and rapid initiation of therapeutic interventions have to be immediately started. For example, a surfactant in a case of a newborn and volume resuscitation in a case of trauma victim. So, the golden hour of trauma, it basically involves system of trauma centers, the trauma teams, aeromedical transport support, and the entire effort is to get to the victim to appropriate care within the first hour of trauma. This terminology is not scientifically supported, but it is very well used, because this is the time period in which the transport and the stabilization is important. However, the definitive treatment is given after the patient reaches the center. However, in case of a neonate, the definitive care is involved in the first golden hour itself. That is, in golden hour of neonatology, It involves providing a definitive care to the newborns in the stabilization area itself. We are specifically referring to the initiation of treatments in a systematic and efficient manner. Also, the neonatal resuscitation is a complex process, and it takes place in extremely dynamic and complex environment where communication and team effort is foremost important. Thus, the promise of the golden hour in neonatal care lies not only in evidence-based treatment but also in the team structure, communication, and the proficiency. It is a teamwork, not a single person's work. So, what are the golden hour strategies in a periviable neonate? The golden hour strategy is a philosophical approach that reinforces the communication and collaboration using evidence based protocols and procedures that standardize as many elements as possible for delivery and the initial management of a very preterm birth. So, let us discuss what are the problems that we see in these periviable neonates, stabilization itself. Now, periviable generally means the neonates who are as close to 20 weeks, that is, they may range from 20 to 28 weeks. The smaller the neonate, the issues which we are discussing are more exaggerated in him. And as we are saving more and more lives, as we are resuscitating smaller and smaller babies, it is very important that the resuscitation is done in the optimum manner so that we are not harming the baby neurologically or the other systems are not getting harmed. Basically, we are now interested in intact survival rather than just a plain survival. So, what are these problems? These babies are more prone to hypothermia. We have discussed in one of the initial lectures that they are more prone to hypothermia because they have extremely immature skin, they have minimal developed epidermal barrier, they have lesser of the fat deposition. Especially we are talking about the brown fat because this is the center for the non-shivering thermogenesis. Then they have increased body surface area to mass, so there is more area from which heat loss can occur. Then ineffective non-shivering thermogenesis. As I've already mentioned, the brown fat stores are lesser in them. Secondly, these babies have very poor energy stores. As they are born earlier, they don't get enough of the stores which are available from the mother and which normally are transferred to the baby during the last trimester. So these babies, they lack it. The immature tissues are easily damaged by hyperoxia. So we are not just worried about hypoxia. Hyperoxia is also a silent killer for us. So we need to look at that. They have weak chest muscles that limit adequate ventilation. So ventilation may be a point of issue in these babies. They have immature nervous system because of which there can be a poor respiratory drive. So it is not just the respiratory system but the respiratory drive per se can be problematic in these babies. Then they generally have surfactant deficiency that may contribute to poor lung expansion and the gas exchange. So postnatal given exogenous surfactant generally helps these babies. They are at increased risk of infection because the immune system is underdeveloped. Along with this, most of the barriers, that is the skin, even the mucosal membrane, they are very immature because of which the organism can harm the baby. Then they have fragile capillaries within the immature brain which can rupture easily, and that is why IVH, that is intraventricular hemorrhage, is very common in these extremely low birth weight and extremely premature babies. They have a small total body volume, total blood volume, that makes them more susceptible to the hypovolemic effects of blood loss. And the parents are highly stressed. So this is one of the factor which is very important in the management because we have to manage that as well. Coming on to resuscitation specifications, I will not go into too much details of it, but as we know, the resuscitation in a newborn has to be done in accordance to the recommendations by neonatal resuscitation program, and these are the steps given. Each and every person who's practicing neonatology has to be well versed with the neonatal resuscitation program. Now, this is the golden hour checklist. Now, what we do in the delivery room is very important for the future prognosis of this baby. So, it will be very good if we have a complete checklist so that we know what have we missed and what exactly are the important things that we should not miss. Along with this, there is a separate right hand side which you can see where the feedback can be given so that we can know where exactly is the team lacking and what are the points where the team can improve, because as we have discussed, the golden hour concept is based on teamwork. It is not an individual person managing the baby, it is a complete teamwork. So this checklist will help a lot. Now coming on to some of the steps which are specific to prematurity that we'll be discussing. So, firstly, it is the delivery room temperature stabilization. Secondly, delayed cord clamping. Then comes the delivery room respiratory support, delivery room oxygen use, and cautious use of cardiac compressions and medications. Now, these are the points which we'll be discussing in brief. So, let's proceed. The delivery room temperature stabilization. The temperature management in a premature baby. Now, the thing that we have already discussed, but once more, the very low birth weight and extremely low birth weight babies, they are unable to respond to the thermal stress because of lesser of the brown fats, decreased subcutaneous fat, so lesser of the insulative capacity, ineffective thermogenesis. This comprises of shivering as well as non-shivering thermogenesis. Then increased transepidermal water loss and inability to take in enough calories which can provide nutrients for thermogenesis. These babies are very small. They generally are kept NBM for the initial few days, or we may start just trophic feeds. But the calories which are received from this are not enough for thermogenesis, and they have decreased glycogen stores. So, what are the temperature management strategies in these babies? First and foremost is increasing the ambient room temperature of the delivery room itself or the operating room to 25 to 27 degrees Celsius. Most of the time our operating rooms where the baby is being delivered has air conditioner which is going on. So please ask the gynecologist to shut down the air conditioner for the time period of resuscitation of this premature baby, because this will help in the temperature management. Then surfaces that come in contact with the infant or are close to the infant, including the towel used to catch the baby and dry the infant, must be pre-warmed. This is a very important step. Along with this, it is also important to note that once the initial wiping of the baby is done, the baby is received in the pre-warmed towel itself. Once the wiping is done, it is very important to change the towel immediately so that the wet towel is not being in contact with the baby for a long time. Then strategies for drying must ensure that the 2 or 3 cell layers of the poorly supported epidermis are not removed. There is no need to remove the entire covering which is present, because that is basically a physiologic method of preventing um, temperature loss. Now, it is essential to understand that radiant heaters cannot solely achieve a positive energy balance to warm the premature infants immediately after birth, and that the use of occlusive wraps in the delivery room for any infant who is less than 29 weeks gestation significantly improves the admission temperature. So, it is recommended that a baby, especially if a baby is less than 24 weeks, then immediately first place the baby in a plastic wrap and do the resuscitation, keeping the baby in a plastic wrap as much as possible, because this will help to prevent the heat loss as well as the water loss to a great extent. Second to this, whichever baby is hemodynamically stable can be given directly to the mother for kangaroo care. That is, the baby can get direct skin to skin contact through mother, and this can help in the temperature management as well. So, the periviable infant should be placed in a high dithermency food grade plastic, that is polyethylene bag or wrap, without the initial drying up to the level of shoulders at least. The preterm infants can be placed on a chemically activated thermal mattress that improves the temperature stabilization. The head is the area from which maximum of the water loss as well as the heat loss occurs. So this has to be covered with a polyethylene plastic cap or a woolen cap, and monitoring the infant's temperature in the delivery room to guide the further interventions. And also we need to provide iatrogenic hypothermia in these babies. Coming to the next step, that is delayed cord clamping. So delayed cord clamping, this is a concept which has come up for especially for the smaller babies. Now the question of optimal time to clamp the umbilical cord after delivery is still controversial. Now, there have been systemic reviews of the trials which suggest that for an otherwise uncomplicated preterm birth, delaying cord clamping for 30 to 180 seconds following the delivery improves blood pressure, increases and decreases the need for blood transfusion, and decreases the incidence of IVH in these babies. However, there are limited data regarding the hazards or benefits of a delayed cord clamping in a non-vigorous infant, and almost no data regarding the periviable neonates. That is, in a non-vigorous baby, again, delayed cord clamping becomes very practically difficult because this baby requires resuscitation, so it has to be separated immediately from the mother, taken under the warmer, and the resuscitation process has to be stopped. So cord clamping, delaying the cord clamping can be a bit difficult here. Recently, elegant preterm lamp studies at the time of birth examined the effects of early versus late cord clamping on transitional hemodynamics. These studies have demonstrated that early cord clamping leads to a rapid decrease in preload to the heart, which results in bradycardia and decreased perfusion, unless there is a prior establishment of increased pulmonary blood flow via sufficient inflation and ventilation of the lungs. So the results were that delayed cord clamping in fact benefits blood pressure, and it decreases the risk of IVH in the babies. Investigators have also suggested that delaying cord clamping until after ventilation onset might lead to a smoother transition to the newborn life. But further studies are needed, and the solutions to the ergonomic difficulties, that is, the practical difficulties of providing effective ventilation while attached to the placenta, still needs exploration. So we may have proper guidelines coming up in very near future. Coming on to third, that is delivery room respiratory support. So now what are the goals of a delivery room respiratory support? It is to achieve adequate minute ventilation by improving the lung compliance, by decreasing the work of breathing for the small baby, by avoiding apneas, and providing assisted ventilation as and when need arises. And as we know, now there are certain evidence-based strategies for providing respiratory support to these babies. Firstly, sustained inflation. Small clinical trials have suggested that sustained initial inflations, that is 10 to 20 seconds, may reduce the need for intubation and bronchopulmonary dysplasia development. This is, however, still under study, so we may get the guidelines in very near future. Secondly, coming on to CPAP use. Now, immediate application of CPAP to prevent the collapse of the surfactant deficient preterm lungs reduces the need for intubation It may reduce the need for exogenous surfactant administration as well and the total duration of ventilation. But CPAP use has not shown to reduce the rates of bronchopulmonary dysplasia. Thirdly, coming on to intubation, because this is one more respiratory support which some of the babies may require immediately within the first hour itself. Now, it is quite possible that a periviable infant will need effective positive pressure ventilation and intubation for stabilization. Studies have demonstrated that although about half of the 24-weeker infants can be stabilized on CPAP in the delivery room, very few infants of less than 24 weeks avoided delivery room intubation. So, delivery room intubation has been so common for these periviable neonates. If a baby is intubated, then early use of surfactant may be beneficial. And looking at the baby and the clinical condition of the baby, we can decide whether we want to extubate the baby and put him on CPAP immediately after surfactant, or whether we need to continue the ventilation for 24 hours, after which we may extubate the baby. Coming on to the oxygen in the delivery room. Now, oxygen use, the current guidelines says that you have to use oxygen as a very important drug. That is, you need to use it only and only when required, and the optimum use is very important, because now we have come to know that hyperoxia can be as damaging to a periviable neonate as much as hypoxia could be damaging. And retinopathy of prematurity is a nightmare for the parents as well as the pediatricians, and that is something which can be avoided by our optimum use of oxygen. So we have to use oxygen very meticulously. So what are the strategies? We have to avoid hypoxia as well as hyperoxia during resuscitation of a preterm newborn. Oxygen toxicity can cause morbidities like, first and foremost, retinopathy of prematurity, even bronchopulmonary dysplasias, or in certain cases, intraventricular hemorrhage can even be caused due to it. So, blended oxygen is advocated for neonatal resuscitations so that we can control how much oxygen we are using. The no specific starting concentration recommendations are made for preterm babies, but ranges between 21 to 40 are generally used. For a term baby, the resuscitation guidelines clearly mentions that the baby has to be resuscitated at room air. In the preterm as well, we can decide this on the basis of pulse oximetry. You can start the resuscitation at room air, that is 21% of oxygen, and as the pulse oximetry will guide us whether we need to increase the oxygen, it is always better to step up than step down. The optimal starting concentration of oxygen for preterm resuscitation is still an active area of current research. So we may come to know about it in a small time period. Pulse oximetry is a must at every delivery of a periviable neonate, because as we said, our oxygen level will be decided on that. The pulse oximeter sensor is placed on the right hand or the wrist. That is, the preductal saturation is important, and subsequently connected to the monitor for the quickest and the most accurate signal. The optimal goal saturations per minute of life have not been determined yet for periviable neonates or the extremely low birth weights. So we can currently take the standard guidelines, but we need to remember that they are for term babies. So we should not go very high on our oxygen. The current recommendation is to use the interquartile range of oxygen saturations of healthy term infants as the goal. And lastly, coming on to the cautious use of cardiac compressions as well as the medication. So again, the word which is important is having caution. Now for extremely low birth weight babies, compressions, that is chest compressions and medications, are prognostic markers for adverse neurodevelopmental outcomes. Now, These babies who receive chest compressions and medications in the delivery room have a 15-minute Apgar score of less than 2. They have only 14% chance of disability-free survival. And given the high rates of poor outcomes, families may decide in counseling before birth that they prefer to forego trials of chest compression as well as medications if the initial ventilatory support fails to stabilize the heart rate of their periviable neonates. So the counseling, that is the counseling before delivery of the baby, is very important so that the parents can decide at that stage itself whether they want to go ahead with resuscitation and till what step they want the resuscitation to go further to. So coming on to the conclusion part, what is the takeaway message? Now the first hour of life for a premature infant represents a time period during which the infant faces challenges that carry risks of short as well as long-term injury, lifelong developmental delay, and even death. An immense number of complex decisions and tasks must be accomplished in a short period of time following the birth of a periviable infant. The golden hour of neonatology, unlike the golden hour of trauma, involves providing a definitive care to the newborn in the stabilization area itself, especially the initiation of treatments in a systematic and efficient manner. A standardized approach using the best possible evidence based strategies should be therefore used. Um, just to sum up, increasing the ambient room temperature before delivery, pre-warming the surfaces and tiles to which the neonate is going to be exposed, use of a high diathermancy food grade polyethylene bags or wraps, then use of caps, thermal blankets, temperature monitoring of the infant can help a lot in achieving the optimal temperature management and to prevent iatrogenic hyperthermia as well. And for an otherwise uncomplicated preterm birth, delaying of the cord clamping for 30 to 180 seconds following delivery is advocated currently. Providing optimum respiratory support during resuscitation is very important in the form of positive pressure ventilation use, CPAP use, or intubation, plus or minus surfactant administration as and when needed. For preterm babies, oxygen range between 21 to 40% is generally recommended for use during resuscitation. However, the optimal starting concentration of oxygen for the preterm resuscitation, especially these periviable babies, is an active area of current research. Every periviable infant resuscitation requires a pulse oximetry use so that the oxygen can be controlled depending on the pulse oximetry readings. For extremely low birth weight babies, chest compressions as well as use of medications during the neonatal resuscitation are prognostic markers for adverse neurodevelopmental outcomes. So the parents have to be counseled beforehand about all these possibilities. And the most important goal is to provide the least invasive support needed while always being prepared for the worst situation. And here we come at the end of our presentation. Thank you so much. Hope you guys find this presentation useful. And do remember to like this video and subscribe to the channel Neonatal Hub for more informative neonatology topics. And I'll be looking forward to your comments on what are the other topics that you are interested in getting the presentations on. I'll try to bring those topics. Thank you so much.